Sorry for a little small delay because of some simple technical reason. Of today, we are going to start the session of the year case presentation of 2026, the first of the session in this year. And to discuss the case, we have two giant teachers. Dr. Vinita Shobha, most of you know, she is the professor of Department of Clinical Immunology Rheumatology at St. John's Medical College. She is one of the innovators who is working on a lot of well-organized collaborative research, and her keen interest is in both in myositis as well as in systemic lupus erythematosus. The second faculty is Dr. Dharmanand BG, our past president, and who is a well-known teacher to most of us. And his interest area is fibromyalgia and pain management, and he has a lot of his papers to his credit. Welcome, Dr. Dharmanand. And today's presentation is done by Dr. Vishnu Priya. She is the DRNB student first year in St. John's Medical College. Over to Dr. Vishnu Priya. Without losing much time, I ask Dr. Vishnu Priya to present her case, and I request teachers to discuss at multiple places where exact interventions are required. Vishnu Priya.
Thank you so much, sir. Good evening, everyone, and respected teachers. I'm Dr. Vishnu Priya, third year DRNB resident from St. John's Medical College and Hospital. Today, I'll be presenting a case. Coming to the case details, 38-year-old gentleman, Mr. X, hailing from Bangalore, educated up to 2nd PUC, currently working as a food delivery partner, and informant is patient himself, who is a known case of psoriasis since 10 years, presented with chief complaints of worsening of skin lesions since 4 years and multiple joint pain since 4 years, and also lower back pain since 4 years, and complaining of difficulty in walking since 7 months. Coming to history of present illness, 10 years ago, around in 2016, he noticed flaking of skin, scalp, reddish raised scaly lesions on both arms, ears, which was not associated with itching and insidious in onset. And he has also noticed a worsening of these skin lesions in the winter season mainly. And he went to dermatologist where he was diagnosed as psoriasis and has advised topical agents. However, he has lost to follow-up and took homeopathic medication for the skin lesions, with which the skin lesions got improved and continued the same homeopathic medication for the next 2 years. And during that period, he has no history of any weight gain or striae over the abdomen. So 1 year after stopping the homeopathic medications, he had recurrence of the similar skin lesions, which has improved with topical agents given by a dermatologist. And also he had similar type of minor skin lesions, minor skin worsening 3 to 4 times over the next 3 years. And he has taken the topical agents for the same lesions. And 5 years after the onset of the illness, that is in 2021, he has developed significant worsening of the similar skin lesions with severe scaling and crusting involving the new areas like chest, abdomen, back, and also legs. During the same time, he has also noticed some nail changes also. He simultaneously developed multiple joint pains which were bilateral, symmetrical, additive, involving small and large joints, associated with swelling of joints and early morning stiffness lasting for about 1 hour. And also he developed lower back pain with early morning stiffness more than 1 hour, worsening with the rest and relieving with the activity and the NSAIDs at the same time. At that time, he had difficulty in using Indian-style commode and climbing staircase and also driving. But he was continuing his job at that time despite of severe difficulty. For these complaints, he has consulted rheumatologist and was started on tablet methotrexate 5 mg per week. As he did not improve significantly with that, dose was gradually escalated to 25 mg per week over a period of around 6 months, and also tablet as 30 mg per day was added. With that treatment, he had partial improvement in the symptoms, that is around some 30 to 40%. However, he continued taking NSAIDs 1 to 2 times per week because of joint pains. Over the past 1 year, from 2025 onwards, he also developed neck pain, which was insidious in onset with early morning stiffness, lasted for around 1 hour, which was gradually worsened, followed by restriction of the neck movements, and has a difficulty in looking over his shoulders. And also he developed a swelling of entire right finger 1 year back, which was associated with the severe pain suggestive of dactylitis. Took NSH for the same and which got resolved within 2 weeks. And also, despite of taking all these medications also, and he has noticed the deformities of his fingers and toes since last 1 year without affecting his functional capabilities of personal care. And progressively, he has developed difficulty in walking for the past 7 months, and also limping while walking while with the feet wide apart. And he has also noticed a difficulty in climbing the staircase, squatting, with progressive worsening of the groin pain in both sides, right more than left. And for this worsening of the symptoms, he was continuing methotrexate 25 mg and apremilast, and also he was taking NSAIDs 2 to 3 times per week. So to sum up all the joint symptoms, he had inflammatory low back pain for the past 5 years and inflammatory neck pain for the past 1 year. And coming to the peripheral symptoms, he had inflammatory bilateral symmetrical additive joint pains involving large and small joints for the past 5 years, and gradual bending of his fingers and toes since 1 year, and associated with the difficulty in walking for the past 7 months. However, he didn't have any history of heel pain, back of the ankle pain, chest pain, and any other interstitial sites pain, and no history of painful red eye in the past, or photophobia or blooding of vision, and no complaints of altered bowel movements and blood in the stools and the weight loss, and no history of frothy urine, decreased urine output, pedal edema, or facial puffiness in the past. So in view, despite of taking the treatment and in view of worsening of the symptoms, he visited us 40 days back. After necessary evaluation, he was started on injection adalimumab 40 mg once in 2 weeks. So far, he has taken 2 doses of adalimumab, followed by which there was significant improvement in the skin and also joint symptoms of the patient. Coming to the past history, no history of diabetes mellitus, hypertension, dyslipidemia, cardiovascular events, stroke, or depression in the past. And coming family history, his younger brother was diagnosed with psoriasis at the age of 31 with no joint symptoms, and he was on treatment for the topical treatment for the skin involvement. Personal history, is a reformed smoker. He used to take 1 to 2 cigarettes per day 15 years back. He has taken around for 1 to 2 years. Not an alcoholic. He consumes mixed diet, and bowel and bladder habits are normal. Coming to the drug history, he has taken over-the-counter medications for around 2 years in 2016 for the psoriatic skin lesions, and on tablet methotrexate 25 mg per week and tablet apremilast 30 mg per day since 2021. And also he is taking NSAIDs frequently for the past 5 years. So coming to the summary of the case, he's 39-year-old gentleman who is a reformed smoker and known case of psoriasis since 10 years. Developed worsening of the skin lesion since 5 years with deforming bilaterally symmetrical additive inflammatory polyarthritis and inflammatory back and neck pains from 5 years, with limping for the past 7 months, with nail changes, and also 1 episode of history suggestive of dactylitis 1 year back, with no features of uveitis or enthesitis, and as history is not suggestive of any nephropathy secondary to the chronic NSAID abuse. Can I go ahead with examination also, sir?
No, I think we can have any discussion around.
Vinita? Vinita, you're muted, I think.
So your interpretation, it is quite clear that this patient has psoriatic arthritis, or would you like to consider any other differential diagnosis?
No, ma'am. As he has history of psoriasis and psoriatic-related nail changes, and also history of dactylitis, in view of all things, like I'm considering only psoriatic arthritis as the main differential.
Okay. So what are the poor prognostic markers for psoriatic arthritis? How do you know whether a patient is going to do badly on treatment or not?
So at the baseline, if the patient has very bad skin involvement along with the polyarticular involvement from the onset of the disease, and also involvement of the nails and enthesial involvement, and also dactylitis with axial involvement, these are all the poor prognostic factors which will determine the course of the illness.
Does the extent of psoriasis?
It usually is not associated much with the
Is it a risk factor for developing psoriasis? If I have psoriasis, I have an extensive psoriasis. Do I have a higher risk of developing psoriatic arthritis vis-a-vis somebody else who has only one patch in the scalp?
No, sir. Like there are some extensive involvement of the psoriasis per se not associated with the joint involvement. Patients who have scalp involvement, intergluteal involvement, those patients have higher risk of developing articulars rather than extension.
I think the extent of psoriasis is also a risk factor for developing psoriatic arthritis in future. What you are telling is scalp, buttock, umbilicus, these are all hidden areas of psoriasis where you have a patient with what looks like psoriatic arthritis, but you don't get a psoriasis. It doesn't give the history of psoriasis where you have to look for psoriasis in these hidden areas behind the scalp, one patch behind the scalp, one in umbilicus, behind the buttock, or a bit, below the breast. These are the areas, hidden areas where you might miss. I think extent of psoriasis, presence of nail psoriasis, palmoplantar psoriasis, these are all risk factors for development of psoriatic arthritis as well. Okay, if you have this patient from the beginning, he had extensive psoriasis and has polyarthritis and inflammatory spondyloarthritis like presentation, right?
Yes,
And nail changes. So what would be your first choice of drug in these patients?
So for my choice of drug will be based on the extensive skin involvement, interleukin-17 inhibitors, if patient is affordable.
Will that
Or
cover all the domains of the patients who has? The patient has multiple domains now, has a polyarthritis, psoriasis, extensive
Yes, sir.
psoriasis, nail, and inflammatory back pain.
Yes, sir.
So your first choice will be IL-17.
Yes.
If cost is not a problem, economy is not a problem, IL-17 could be. What are the other choices?
The TNF
IL-17.
inhibitors I can use in this patient, sir.
Okay. If both, he can't afford both. He can't afford biologicals. Is there any other drug?
He's just 39 years and he doesn't have any comorbidities and also family history of young onset of stroke and all. So I can use JAK inhibitors also, sir.
JAK inhibitors, would that cover most of the domains the patient has?
Yes, sir.
Okay. What about apremilast?
So apremilast will not have that much effect on the axial involvement, sir.
Right.
So even though it will cover.
What
So
about
methotrexate?
methotrexate?
No, sir. Like axial involvement, he has very bad
So
symptoms.
in this patient, methotrexate is probably effective in skin domain and
Yes,
the
sir.
polyarthritis domain.
Yes.
And the rest of the domains, it may not be effective. So why this is important is the choice of drug in psoriasis and psoriatic arthritis probably would depend upon which domain is dominating in this patient. So sometimes if you choose the wrong drug, which is not going to be effective in the domain, then patient might lose the time and damage might set in. So that's the importance. So anything else, Dr. Vinita? Chandrasekhar?
Yeah. Given the choice, would you allow to give me a few more differential diagnoses? I would like few more DDs. Because the rule book is that unless you have a DDs open, your thinking process for further either evaluating, investigating the patient gets too restricted. The error in missing and unusual presentations will be there. So can you just put few DDs in this particular patient?
Sir, if nail changes would not have been there, I would have, but the history is so long. Reactive arthritis, other spondyloarthritis spectrum can be considered, sir. It could be like IBD, arthritis, and reactive arthritis, but this patient had nail changes, which will further narrow down my DDs.
If I ask you to give me two different diagnoses, one for skin, one for arthritis, what's your approach?
So for only for peripheral arthritis, I can consider rheumatoid arthritis as one of the differentials, sir. Only for the peripheral arthritis.
What about the skin?
For the skin,
What are the skin of a lesions of a psoriasis, which is often confused the diagnosis goes on pulling, either calling it with a different name or calling it as psoriasis and going on for a long time. Can it be a dry eczema?
Eczema can be there, but so much of scaling and crusting he had, sir.
Dry eczema can.
Yes, sir.
Okay, what is there any rheumatological non-psoriasis, rheumatological disease which can cause skin rashes which look like psoriasis? May not be to this extent, nail changes, no. But can it be mistaken as psoriasis?
Yes, sir. So keratoderma planoregicum, which is caused by the reactive arthritis, can be mistaken for palmoplantar psoriasis.
Yes. Any other disease? Any connective tissue disease?
DLE lesions sometimes can be mistaken for the.
There is one more, apart from DLE, there is one more skin lesions in SLE. Few more, I mean, SLE has many lesions.
Yes.
What is subacute cutaneous lupus?
He can have the lesions like that psoriatic related. It looks like it's because of the scaling and all.
There are two different types of subacute cutaneous lupus. One is psoriasiform, isn't it?
Yes, sir. There is an yes, sir.
And very rarely dermatomyositis also can have lesions which look like psoriasis. It's not uncommon in practice. Dermatomyositis rash initially being treated as psoriasis.
The message here is actually, you are to keep your differentials open till you prove otherwise. Yeah. Please go ahead. Let's go ahead with the next.
Coming to the examination, vitals of this patient, the patient was conscious, oriented to time, place, person, and blood pressure was 130/76 mm of Hg in the right arm in sitting posture. Pulse rate was 78 per minute, regular. All peripheral pulses were palpable, and SpO2 was 99% on room air. Respiratory rate was 21 per minute. And coming to general physical examination, which was done on 18th of this month, and height was 176 centimeters and weight was 82 kgs, and blood BMI was 26.5 kg per meter square, which is of overweight, and weight circumference was 94 centimeters, which is with the normal limits, and no pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema, and oral cavity examination was normal. Coming to the skin examination, there were extensive non-erythematous to mild erythematous blocks with silvery scales present over the skull, beard area, anterior chest, abdomen, and lower back, arms and legs, and areas of hyperpigmented macules present over the arms and legs. And PASI score was 8/72, and with body surface area involvement of 34%, and no xanthomas, xanthelasmas were noted, and pupil was no irregularity was noted. Iris depigmentation was not there, with reacting normally to light, and no stria over the abdomen. These are the skin lesions where we can see that multiple non-erythematous hyperpigmented maculopapular lesions with some scaling and crusting over there, with some there are areas of clearing also we can see. On the other hand, we can see the severe scaling is there. These are the lesions over the lower limbs where we can see the faint erythematous maculopapular lesions with some areas of clearing and also crusting and scaling and indulation is noted on some lesions. And there was pitting over all the nails of the right hand and first and fourth nails of the left hand. And also over the right first and second nails, and also left first, second, and third toenails. And onycholysis of the right fifth nail and second nail was noted, and subungual hyperkeratosis of the bilateral great toenail and fifth nail was noted. And here we can, actually it's not visible properly, and NAPS scoring is coming around 19. So coming to the musculoskeletal examination, gait was broad-based gait with right leg.
Can you stop right here, Vishnupriya, and tell us how you did the NAPSI scoring?
Yes, ma'am. We have to divide each nail into 4 quadrants, ma'am, with one vertical and one horizontal line. So if any skin lesion, any nail lesion, that could be a nail plate or nail bed lesion, we have to give 1 score. So total 20 nails are there, 24 is 80. So if if it's present in the all quadrants, like that, we have to take.
Okay. So what are the classical nail changes you know of psoriasis?
So nail plate changes are leukonychia, pitting, and crumbling. And nail bed changes are onycholysis, subungual hyperkeratosis, salmon pink sign, and also splinter hemorrhages schemes.
And in your opinion, which is the best? We already discussed the biologics for psoriasis, psoriatic
Yes, ma'am.
arthritis. Which is the best or the most effective medication for nail psoriasis?
Ma'am, like interleukin-17 inhibitor, secukinumab and ixekizumab has noted very good improvement in the nail changes, ma'am. And also even TNF inhibitors also has shown good effect.
So which is most effective?
Secukinumab.
What percentage of patients? Do you know the numbers? In which trial have they specifically looked at nails? Have they looked at the nail subset in any of the trials?
Yes, ma'am. In future 2 trial, they have noted the nails, dactylitis, and also enthesitis in particular.
Okay. Continue.
Yes. Coming to the musculoskeletal examination, gait of the patient was broad-based gait with right leg flexed at hip and knee and externally rotated. And attitude of the patient in the supine position is lying in a supine posture with arms by the side of the body, and right hip is flexed, abducted, and externally rotated with knee in flexion, and left leg was in neutral position. Coming to the upper limb examination, shoulder, elbow, and the wrist, skin over all these regions were normal with no swelling, with full range of active and the passive range of motion, and also no joint line tenderness was noted. In the hands, swan neck deformities were noted in the bilateral third and the fourth digits, which are correctable, and range of motions are normal in all the joints, and grip strength was normal, and no stigmata of dactylitis was noted, and no muscle wasting was seen. Coming to the lower limb examination, hips, skin over bilateral hip region is normal with no scar, sinuses, or swelling. And right hip is flexed, abducted, and externally rotated, whereas left hip is neutral position. And joint line tenderness was present in the right hip. And coming to the range of motion, it was decreased on both the sides, right more than left. And flexion, he was able to do only 45 degrees, and left side it was 70 degrees. And extension, he was able to do only 20 degrees and on both sides. And abduction was 10 on right side and 20 on left side. And adduction was 20 on right side and 15 on left side. Whereas external rotation was 25 on right and left is 20. And internal rotation was 10 on right and 25 on left. And also true length was same on both the sides. Whereas apparent length discrepancy was noted, and right side was short when compared to that of left side by 2 centimeters. And coming to the knee examination on inspection.
How did you, once again, Vishnu, how did you measure the length?
So true limb length was measured from ASIS to medial malleolus, sir. Apparent limb length was measured from xiphisternum tip to the medial malleolus, sir.
A patient has got flexion deformities in the hip and also knees bent. How do you measure? I don't think that you need to measure this in this case.
So true limb length, I have taken the bony landmarks, sir. From the ASIS, I've taken till the...
Yeah, but still, it is not very valid in somebody has got a flexion deformity unless you track your tape through the bone and go there. So you can't do just one line here and say that it is long, but it is already flexed. So there is no relevance in looking for a limb length discrepancy. Only when look normal, a slight limp is there while walking, then you can measure that.
Okay.
So in the presence of flexion deformities, these measurements may be of not relevant. So you will be, it's not an info which is really look for or will help you.
And also hip generally joint line tenderness is not really looked for. Hip tenderness is measured mainly on hip movement. If hip is tender and moving, it is a tender joint. So it's generally not palpated. It's not very reliable palpation. It is a sensitive area anyway. If present in normal people also, it might hurt.
Okay. Shall I continue?
Yes, yes.
Please go ahead. Go ahead.
Coming to the knee examination, inspection, it was normal. The skin and no swellings were noted in the anterior, lateral, and also posterior regions. And right knee is in slight flexion, maybe due to the hip deformity, because when he's able to stand, it's like getting corrected, and full range of motion is present in the knee joint, both active and the passive, and no joint line tenderness was noted.
It is
And
unlikely to get corrected on standing.
yes, but we have seen multiple
No,
times.
when he already has a flex deformity, how can he straighten up when he's standing?
Sorry, sir?
When he's already having a flexion deformity in the hip, when he's standing, it's difficult for him to straighten up. You could examine when he's lying down, knee is bent. You at a bent knee, you may be able to move fully.
Yeah,
So
it
that
is.
is how we know that knee is moving well. Knee is in a bent position because of the hip flexion here.
Yes.
While standing, you may not be able to fully straighten up. He
But
may
while
be able to
walking,
reach.
yes, but when walking, it's getting corrected. Like it's not bent, sir. It's like normal. Only in the supine posture, it's getting more prominent.
Okay, okay.
So coming to the foot and the skin over the region is normal and MTP squeeze test is negative. There are some deformities noted in the foot region, that is hammer toe deformity of the bilateral second toe and fixed flexion deformity of the bilateral third and fourth toes were noted. And overall TJC and the SJC is 0 and no enthesial tenderness was noted by all the leads and masses and also spark enthesitis scores.
You don't think the fourth toe is a sequelae of dactylitis?
But he had no history of that, sir. Actually, he had trauma of that when he was some 8-year-old, sir. That is hyperpigmentation because of that he was telling. Was there?
I don't know, trauma, how big the trauma is. Many times you have to go a little more clearly because people attribute any illness to the recent trauma, but the trauma sometimes many times is trivial. It looks very dactylitic and deformity looks like post untreated dactylitis. It's what it looks like very clearly. So anyway, subject to interpretations.
Can you tell us about the entheses? How did you assess for them?
Ma'am, there are 3 enthesitis scores are there, ma'am. One is least, it's the shortest one, which has 3 points. One is the humerus lateral epicondyle, medial epicondyle of the femur, and Achilles tendon. And
so total 6.
Yes, ma'am, 6, 3 on each side. And spark enthesitis score is there, ma'am. That is for the peripheral enthesitis score. That it has insertion of the supraspinatus tendon and anterior medial and the lateral epicondyle of the humerus and greater trochanter and the lateral and Achilles tendon and plantar fascia insertion. Coming to the masses, it involves mainly the central enthesis, axial enthesis, that has 2nd and 7th costochondral junction and L5 and anterior superiliac spine bilaterally, iliac crust and Achilles tendon.
So he has no tenderness on any of those sides?
No, no.
Okay. Continue.
So coming to the spine examination, on standing, cervical and thoracic spine appears normal with loss of lumbar lordosis, and there were no swelling or any skin changes noted in the spine, and no facet joint tenderness, and SIJ compression test was negative. Coming to the cervical spine examination in detail, inspection, it was normal, but restricted range of motion was noted, with lateral rotation of cervical spine of around 45 degrees on each side, and cervical rotation, and bilateral lateral flexion is 50 degrees, and flexion of 45 and extension of 20, with chest expansion of around 5 centimeters, which is normal. And we have done BASMI for this, and tragus to wall distance is 13 centimeters, and cervical rotation is around 45 degrees, and modified Chobas was 4 centimeters increase is there, and lateral flexion on the right side is 25, and left side it is 14 centimeters, and intermalleolar distance is around 107 centimeters, and occiput to wall distance is 0. So we have taken BASMI 10, it is coming around a score of 4.6. Coming to the other system examination, it was normal.
In the other system examination, is there anything specifically did you search for?
Yes, ma'am. As patient is a long-standing case of this one, like psoriatic arthritis and also uncontrolled inflammation, the patient can have this one carotid plaques also, and then we can hear the bruit over there. And because of costochondritis, there will be reduced chest expansion restriction will be there in that. And in the cases of early stages of that NAFLD, we can see hepatomegaly also.
Anything related to his smoking history?
He has smoking history of only 2 years, which is
No.
Right.
Any auscultatory findings or any chest examination findings did you specifically search for?
in SPA. We can search for the ILD also. I mean, the upper lobe fibrosis can be there.
It's not ILD, no. It's not called ILD.
Fibrosis,
Hmm.
upper lobe fibrosis. Sorry.
So in CNS, did you search anything specifically?
Ma'am, like we have searched for the neurological examination completely. There was
No, any specific did you pay attention to?
Neck
Which is
is
the
no.
commonest neurological abnormality do you find in patients with peripheral arthritis?
because of deformities, there can be diffuse atrophy can be there, and also compression, entrapment neuropathy can be seen.
Yeah, so entrapment neuropathy. He's got already deformities of the hand, probably past chronic synovitis at the wrist. So entrapment neuropathy is something which you should pay specific attention to when you are doing a neurological examination.
And also for disc reflexes, because atlantoaxial subluxation
Yes.
involvement of neck is not common, but it can occur in psoriatic arthritis.
So there was no hypertonia, hyperreflexia.
No, ma'am.
Okay.
So coming to the diagnosis of the patient, so based on the history and the clinical examination, diagnosis was made as psoriasis with psoriatic arthritis with axial and peripheral involvement with deformities and with nail involvement and the history of dactylitis 1 year back. And his BASMI is a 4.6, his BASDI of 3.1. He has not yet achieved MDA.
So can you tell us how did you do BASDI and BASMI?
BASMI with all the parameters, 5 parameters, which is cervical rotation and tragus to wall distance and lateral modified Schober's test and lateral spine flexion and intermalleolar distance. With that, we have to give a scoring based on whether we are taking BASMI 2 or BASMI 10. And we have to take average of all those things. By 5 we have to do, then we will get that. And BASDI is based on the 6 features. One is pain due to the, so it's a like vast scaling, 0 to 10 patient has to score. So how much pain is experiencing because of the neck, back or hip pain, and how much of pain is experiencing because of the peripheral joint arthritis, and how much because of the enthesial joints, enthesial involvement, and what is the degree of fatigue he's experiencing. And 2 points for the early morning stiffness. One is duration of the early morning stiffness and 1 degree of early morning stiffness. And 5th and 6th point, we have to take the average and we have to add everything and then by 5. With that, we'll get the BASDI. And if it is more than or equal to 4, it is high disease activity. If it's 2 to 4, it is low disease activity. If it's less than 2, it's considered as remission. Yeah.
Okay. Good. Any questions, Dr. Chandrasekhar and Dr. Dharmanand?
No, it's fine.
No. Yeah.
So
Right.
diagnosis is fairly clear. So there is not much of a differential diagnosis. Long-standing psoriasis with the psoriatic arthritis with multiple deformities and damage. So what is important here is we have a significant amount of damage in addition to disease activity. So the treatment also would depend upon the disease activity and damage. So damage requires surgical solutions and activity requires medical solutions.
Yes.
Yeah, go ahead with the investigations.
So coming to the investigations, before coming to us in March, investigations like it's pretty normal HP, TLC, DLC, And ESR was found to be elevated, which is 26. And after starting the treatment, these are the investigations. ESR has come down to 14, and LFT was normal. And serum creatinine was 1.1, and FBS was 91, and HbA1c of 5.7, with lipid profile was showing increased LDL and also total cholesterol. And total cholesterol was 219, and LDL was 127. And for starting TNF inhibitors, we have done the basic workup. All viral markers were non-reactive, and IGRA and MONTO were negative. So these are the X-rays of the patients, which was done 1 week back. And coming to the first one, it is the X-ray of pelvis with bilateral hip AP view. Here we can see that there is almost ankylosis of the bilateral SI joint. So grade 3 to 4 sacroiliitis is there. And also coming to the right hip joint, we can see that there is severe narrowing of the joint space is there, and subchondral sclerosis. And also the contour of the head is also become irregular, and some erosions are seen, and some enthesophytes are also seen over the great trochanter. And on the left side, there is moderate reduction in the joint space, moderate to severe. And also some enthesophytes are seen at the great trochanter and also the lesser trochanter on the left side. So coming to the second X-ray, it is the X-ray of the knee, AP, and also lateral view. Here we can see that there is mild to moderate reduction in the medial tibiofemoral compartment. And,
is it reliable to comment on joint space in a joint which is not straight and is not standing?
No, sir, that's not.
So this patient joint space looks good. Only a little bit of spiking of a tibial spine is seen. And you can't comment on joint space because patient was not lying down straight, he was lying down with a bent knee. Very difficult to comment.
Okay.
Lateral view looks good, except for a little bit of an osteophyte, some kind of osteophyte on the superior patellar region.
So coming to the treatment, he is currently on injection adalimumab 40 mg subcutaneous once in 2 weeks.
So do you have his X-ray of the hands or feet or chest
no,
X-ray?
No, ma'am, he has not.
Spine?
No, ma'am. Only this sacroiliitis.
Okay, all right.
The question is, would you like to have it?
Cervical spine was also not done, is it?
No, ma'am, it is not done, ma'am.
Okay.
The question is that, would you like to have it? See, there are restrictions, let's leave that. So suppose in an ideal circumstances where you need not consider the budget. So now, would you like to have it or not? If you want, why do you want it?
Sir, as patient had long-standing lower back pain and also restriction, I would like to take a spinal X-ray, sir. Both cervical spine and also lumbar spine. Cervical spine, in order to know about like how much damage is there, and osteophytes, syndesmophytes, how much are there. Because in the long-standing cases, that may also cause a spinal canal stenosis also. So I would like to take X-rays as it is a long-standing case.
So
cervical spine involvement more common in psoriatic arthritis, spondyloarthritis, vis-a-vis ankylosing spondylitis or spondyloarthritis?
Sir, in case of psoriatic arthritis, cervical spine involvement is more common, whereas in case of ankylosing spondylitis, thoracic and lumbar spine involvement are more common disease.
So presence of cervical spine osteophyte, syndesmophyte, should prompt you to look for psoriasis. So that is important. So in a patient who is not known to have psoriasis or psoriatic arthritis, but looks like a spondyloarthritis, but a neck involvement is significantly there. And if there's a huge syndesmophyte, then you should probably actively search for a hidden psoriasis, as you were telling in the first few slides.
Do you have any comments? Sorry.
What's that we was talking about? Skipped lesions. How does it differ from a classic spond in this?
Sir, in ankylosing spondylitis, usually syndesmophytes are like, it starts from the lower down from the lumbar and it will go up, sir. So, and bilaterally symmetrical kind of lesions will be there, which are small, non-marginal. Whereas in case of psoriasis, skip lesions can be there. Like one vertebrae can be involved and next will not be involved. Like there is an asymmetrical involvement, more large syndesmophytes. That kind of picture is seen in case of psoriatic arthritis.
So, Vishnupriya, you have any comments on the lipid profile for this patient?
Yes, ma'am. His LDL is elevated, ma'am. And as patient is like, patient had overweight and also chronic inflammation is also there, which is not yet controlled. I'll ask the patient to take lifestyle modifications like weight reduction, diet changes, and exercise.
So what is lipid paradox?
Lipid paradox is if the inflammation is high, very high initially, LDL can be low in the initial stages, ma'am. But once we start the treatment, LDL can be LDL will go up. But the thing is, whatever LDL, low LDL.
Vishnupriya, we lost you, I guess. Vinita, we can move on. When you can have your comments until she comes back about lipid paradox. That's what.
Yeah, so lipid paradox is something, can you all hear me?
Yes.
Yeah.
So lipid paradox is something which is encountered in people with a lot of inflammatory burden, wherein the LDL can be paradoxically low, as Dr. Vishnupriya was trying to say. So, and once the inflammation is come down, then the lipid rises. So, it is best to look at the lipid profile after maybe 3 to 6 months of initiating the immunomodulatory therapies rather than looking at it and acting on it in the beginning itself.
True. And looking at the lipid parameters also is very important in the choice of drugs. And some of the drugs like JAK inhibitors can increase the LDL. And in a patients with high risk for atherosclerotic coronary vascular disease, so we may have to be cautious in choosing the right kind of a drug. Come back, Vishnupriya. Yeah.
Yes, sorry,
Yeah.
sir.
You can share the.
Yes. So is it vegetables?
Yeah.
Yeah, go ahead.
Like in lipid paradox, I was telling you.
Yeah,
So even in case of low LDL, because of this high oxidized LDL content in presence of high inflammation, so it is also itself is a risk factor for the high serious mortality.
So, would you like to start him on statins right away, or would you like to wait?
First, I will tell him to change lifestyle modifications, like advising him to change the diet and also exercises. With that, I will see the decrease in the.
So, but are you really expecting his LDL or triglycerides or total cholesterol to change because of exercise and dietary intervention or something else?
In these patients, like LDL may be increased due to the insulin resistance also. If he's able to reduce his weight, that insulin resistance will come down, so LDL can be reduced.
I think probably you were switched off. Probably I think Dr. Vinita was telling the point to be appreciated. See, in the presence of inflammation in any of the inflammatory arthritis, usually the lipid profile will be altered just merely because of the inflammation. So you need to wait for the inflammation to settle down before you declare or consider him to be on a high risk for any of the lipid profile intervention, unless there is other reason for you to intervene. So if there is too high a cholesterol beyond what you're expecting, too high a LDL than beyond you're expecting. Paradoxically, in these patients, usually total cholesterol and all those things will be on the lower side. So that's where the point which you have to be sure about it. Yeah.
As I was telling, another factor to determine whether you to treat aggressively or not is the drug you have chosen to give. You have given adalimumab. Adalimumab has got a to a certain extent protective effect on the atherosclerotic vascular disease vis-a-vis JAK inhibitors. If a JAK inhibitor is chosen, probably I would give them a statin. If adalimumab, probably lifestyle changes, we can wait. There is no hurry because a young man with not many other risk factors for coronary vascular disease.
Yes.
Okay, and what else? Treatment?
So if this patient had uveitis, iridocyclitis, you said that your first choice would be secukinumab, right? For a patient with
Yes,
psoriatic arthritis.
Yes.
So if a patient has coexisting uveitis,
No, I would have chosen TNF inhibitors, injection adalimumab.
which TNF-8? Adalimumab.
Adalimumab.
Which one will you avoid for sure?
Etanercept.
So in this patient, as you have seen that the ESR is not significantly elevated
Yes.
and his CRP we don't have a value, and you have not found any tender and swollen joint count, right? So
Yes.
maybe it looks like that he has already got lot of damage with deformities and restriction of movement of the cervical spine and the grade 4 sacroiliitis, hip joint destruction. How are you going to counsel him for in terms of his prognosis?
Like his neck pain, skin lesions, and back pain, that I will tell he will get good improvement with that, ma'am. But based on his X-ray, I will tell him that he may need joint replacement in the future. It will not that permanent
knee or hip?
hip, sir. Hip. Sorry, I have.
Okay, yeah, go ahead. Yeah.
So, like, I will tell him that deformities will not get corrected with the treatment like TNF inhibitors, but only the pain component will get decreased, and skin lesions also will get improved.
Okay, that's a good advice. So what exercises will you advise to him?
Ma'am, for if patient comes to me in pain, then I will just start with the range of movement exercises, ma'am. As this patient doesn't have any TJC and SJC, along with that range of movement exercises, I will also start aerobic exercises and also strengthening exercises and also stretching exercises also for this patient.
So what do you mean by strengthening and stretching exercises?
And strengthening exercise as he has many deformities also and he has difficulty in walking, I'll try to increase the muscle bulk and also strength of the muscles. For that, I will start isometric exercises and also aerobic exercise. Sorry, and stretching exercise is for the to prevent the contractures, ma'am. Because these patients tend to do not do anything and they can develop contractures in the future. So I'll start the stretching exercise and range of movement exercise.
What's the difference between isometric and isotonic exercise?
So isometric is like muscle, while doing the exercise, the muscle fiber length will not get increased. And isotonic is like it will be stretching of the muscle fibers will be there.
Give one simple example.
Like doing dumbbells and all, it is isometric exercises.
So you bringing a dumbbell towards?
Yeah, it is isometric.
Is
Isometric, sir.
It's isotonic.
Tonic.
Yeah.
If you are pushing something and your muscles are not moving, that is isometric.
Yes. Isometric.
What's the difference between eccentric and concentric exercise? Okay, so homework. Anyway, if same example, if I bring a cup of coffee towards my mouth, it is my biceps is doing a concentric contraction. If I'm getting the kind of a full mug back onto the table, it's a controlled extension of the biceps. It's an eccentric exercise. Why I asked is why it is important. Which part of spondyloarthritis spectrum eccentric exercise is very useful. Tendinopathies and enthesitis, lateral epicondylitis, Achilles tendinitis, the best exercise shown to improve is an eccentric type of exercises.
Okay.
So, sorry, Dr. Chandrasekhar, go ahead.
No, with reference to the therapeutics, say you started him on adalimumab, so he comes back after 6 visits or say after 3 months. Still the skin rashes persist. He says, my pain is little better. What are the options you are going to think now? And where do you place him? So what's the next choice you have?
So like if there is significant improvement in the joints, if only skin is very bad, I can still consider interleukin-17 inhibitors, sir. Because in the trials have said that even in the case of patients who have inadequate response to TNF inhibitors also, with secukinumab and also ixekizumab, they have shown good effect on the skin.
What precautions you would take before introducing secukinumab? A patient with both axial and where secukinumab don't work in spondyloarthropathies.
In uveitis as such, it will not work, but rest of
What about IBDs?
Yeah, what about GI?
the GI will not work, sir. It will in fact it will worsen the thing.
Yeah, it is
So-
important to ask for any indirect evidence of IBD before we initiate, because we have had patients whom we have given secukinumab IBD flaring we have seen in practice.
So when you think of IL-17, a little thorough detailing of that, even if you have a little suspicion of a possibility of, what do you do?
So like we can go for direct colonoscopy because calprotectin sensitivity, specificity for the IBD is less, because non-specific inflammation can be seen in many patients also. So it's better to go for the colonoscopy directly, sir, if you're having strong suspicion for the IBD.
You think is it worthwhile to go to directly to colonoscopy or without calprotectin?
We can, if there is strong suspicion, like we can go for colonoscopy, sir. Like the sensitivity of the calprotectin is good. If we have low suspicion, we can get the calprotectin levels done. If it is elevated, then we can go for the colonoscopy, sir.
Actually, this is a division between the gastroenterologist and non-gastroenterologist. A colonoscopist would rightly say that calprotectin is less sensitive, would like this to go for colonoscopy. But normally, as a best way is to just check for calprotectin. If calprotectin is normal, colonoscopy may also not give you a good yield, because most of the time, if the calprotectin is negative, colonoscopy coming negative is very high. So suppose if calprotectin is positive, you may still get a normal mucosa, or you may get something else, because it may also be positive in any other inflammatory conditions. See, what you have to remember is a calprotectin negative is a good for you not to go ahead with colonoscopy. If calprotectin is positive, you may land up with not having inflammatory bowel disease, but at least you have a little more justification to go ahead with colonoscopy. You understood?
Yes.
The what you are saying is correct. It's not sensitive, nor it is specific.
It
But
is
it is
always, yeah, the good history taking is what is the key here. If a patient has got already an illness for 10 years and never had a loose stool or bloody stool, then it is quite unlikely, based on the clinical features, it is quite unlikely that the person will have some degree of GI involvement.
if IBD is positive, what's your next choice?
So if IBD,
So, his brother, you said, is
psoriasis is there.
no. If there is IBD, which drug will you choose? That's your question, right, Dr. Chandrasekhar?
Yeah.
TNF inhibitors works very well for the
So he has
IBD.
failed with TNF. Adalimumab he
I
has
said
failed.
then,
Yes.
so like we can go based on the type, like whether it's ulcerative colitis and Crohn's disease. There is good evidence for the JAK inhibitors like tofa in case of ulcerative colitis, sir. Whereas it has failed to achieve the primary outcome in case of Crohn's disease as such. But phase 2 trials of this upadacitinib and filgotinib has shown very good improvement in case of Crohn's disease also. So it can work both for the axial, peripheral, and also IBD. So I will go for JAK inhibitors.
What about IL-23?
The IL-23 will not work for the axial. So
in this particular case, you would prefer to go to JAK? Okay. Yeah, no, that's the right arguments. No issues on that. Correct.
So his brother is accompanying the patient, and he's, as you said, 31 years old, and he's got psoriasis only involving the skin. He doesn't want to become like his brother. What advice will you give him?
we will tell him regarding the involvement of joints for him, ma'am. So if he gets any joint pains or even mild arthralgias also, we can tell him to visit a doctor so we can perform the scans to look for the subclinical, and we'll keep the threshold very low to start the treatment for him.
Okay. Any other lifestyle advice do you want to give him?
Smoking and alcohol, ma'am, because it can progress psoriasis to
Smoking,
psoriasis.
mainly smoking.
Mainly smoking,
I
yes.
don't know about alcohol use.
Alcohol normally not. So alcohol's
Yeah.
issue is only with methotrexate. So
his specific question is also about diet. So many patients will come and ask you about the diet, right? So what dietary advice will you give him? Anything about exercise? So when you are giving advice to a patient who's not yet developed arthritis, your advice has to be more wholesome, right? The only evidence we have is towards the lifestyle changes. None of the medications in the preclinical arthritis like RA or SLE or anything have ever worked.
Yes.
So your advice you said is about the smoking. Then other components?
Micro trauma and biomechanics also plays an important role in the psoriatic arthritis. Joint protection is the one advice we can give to the patient, ma'am. And also as this one. So if patient is of overweight or obesity, weight reduction and in decreasing the saturated fatty acid food and fatty foods and increasing the protein diet and decreasing the carbs, that will be.
So obesity is an independent risk factor for development of
Yes.
arthritis in these patients. And if you at all you have to give a dietary advice, there are few at least preliminary evidence for reducing the salt and sugar content that seem to worsen the autoimmune disease. Increasing the fiber-rich diet might tilt the gut bacteria population and the immune system towards the Treg than TH17.
Yes.
These are the few things we can give. If it is a rheumatoid arthritis, I will ask them to have a preventive dental checkup. So whatever we can, we have only lifestyle and few modifiable things which we can do. Rest of the things we have to us, and early detection. Secondary prevention is much more easier. Primary prevention is always tough.
So there is something called as Indian adapted Mediterranean diet, which Dr. Dharmanand has already said. So the salt content, the sugar content, then processed food, and then green leafy vegetables. So there is all of those are the ones which have got somewhat some evidence to suggest that these probably will be helpful, if not in preventing progression of psoriasis to psoriatic arthritis, at least keep him healthy in terms of hypertension, diabetes,
Metabolism.
dyslipidemia, and exercise is very important. So that point which you made about obesity is very, very right.
Good. Shall we close?
anything else you have in your slides? I
No,
could
that
see. Yeah,
part
right.
10 antipsychotics indices.
Yeah, I think we have almost come to 8:40, right? Okay. It was really wonderful discussion. I think we could touch on to the various aspects of psoriasis, especially in the therapeutic decisions and how to manage and handle the patients in small cuvettes where how we have to change, alter the treatment. So any final take-home message, Dr. Vinita, Dr. Dharmanand?
Yes, psoriatic arthritis is common. Many a times it is missed because If psoriasis is obvious, then there is no problem. And many psoriatic arthritis patients also linger along in a dermatology circle without adequate initiation of disease modifying drugs. So this leads to deformity. So early detection, early suspicion, early referral, and prompt treatment of psoriatic arthritis is very important to prevent deformities. Nowadays, the therapeutic armamentarium is very wide. 15-20 years ago, we used to struggle to treat these patients with only methotrexate. Now we have spoiled for choices, and we have medicine which can help most of the domains. And thank you, Vishnupriya, for a wonderful case and a nice discussion.
Thanks.
Thank you.
Vinita, any specific things? No.
I think in this
No.
patient, this particular patient, the psoriasis was so evident that we never even considered a differential diagnosis in him. So, but I think what we learned today is that always keep the eyes open, keep the differentials always going, and never to shut the eye on differentials. Thank you.
With that brief note, I think I thank Dr. Vinita, Dr. Dharmanand, and Vishnupriya for the day's case discussion. Thank you very much, and we'll close the session for the day. Thank you.
Good night.
Thank you.
Good night.
Good night.